Hello, everybody. On behalf of the CLL Advocacy Network, I'm pleased to invite you all again to day 3 of CLL Horizons. Wow, what a terrific day yesterday and a terrific first day. I'd like to make a special thank you to all of the speakers and panelists that contributed to yesterday's really inclusive and revealing sessions. There was some really important discussion there, and it was great, you know, across all from the shared clinical and advocacy sessions that explored COVID-related challenges, and then looking at choosing advocacy priorities based upon evidence and resources, really revealing, and how this varies in countries. A theme I've seen coming across on the first one, which was shared in clinical advocacy sessions, was the reliance on collaborative initiatives for to lend weight to a lot of this. And it was really revealing hearing from the regions, on different examples of turning challenges into opportunities, the different strategies and different opportunities from campaigning, and really innovative and interesting one in Israel, from Flute of Light, just being able to provide safe transport during COVID for patients. I just thought that was massively important. It was really great listening to Hema and how well they're doing. I've just got a little bit of housekeeping to do. Just running on to today, I didn't want to run through the agenda, but I think following on from this little introduction, the talks, the Q&A, we then go into an HTA session, which Deborah will be chairing. And then we go into a summary talk of findings from the global survey, which I'm presenting in a recording to you. And then Natasha Bolognese is taking on board a large group discussion with a call to action, looking at current issues and potential actions. So, bit of housekeeping. Can I just let everybody know that during the recordings, please use the right-hand side Q&A function. Any questions you've got, pop them in there. Use the Q&A, not the chat. They'll get to me when I'm chatting with Anna and with Munir. Also, please use the hashtag CLL8Z21. Really great to get some impact out there. Now, most importantly, it's the last chance during today, vote for your best poster. People have put a lot of work into those, some terrific initiatives. Have a good read through and do those. And it would help as well if you'd also feed in your feedback forms if you can at the end of the day. We really need your feedback so that we can shape future horizons. We really want to know what we've done well, what we've done badly, and what your ideas are moving forward. Now, I'm about to now introduce you to what is probably one of the second medical session, really important session, great learnings, really important and terrific advances and terrific insights. So we're looking at ongoing management of CLL, which is going to explore relapsed refractory treatment update, CLL complications, really important. That's going to help raise awareness for you to make sure you're able to share this as well of the complications of people living with CLL. And most importantly, I think also is where are we going in the progress with clinical trials. And our speakers, we have Professor Constantine Tam, or Con Tam, who's Director of Haematology at the Vincent's Hospital. He's clinical lead for CLL and low-grade lymphoma at the Peter MacCallum Cancer Centre in Royal Melbourne Hospital in Australia. And we are also joined by Dr. Talha Munir. He's a consultant haematologist at Leeds Teaching Hospitals at NHS Trust, very, very involved in relapsed refractory treatments, very design and development, very, very involved in clinical research. Professor Anna Shu, who I think spoke the other evening, fantastic clinical researcher, a great friend of us advocates. She's director of the molecular diagnostics and consultant haematologist department of oncology at the University of Oxford, but she's also the chair of the National Cancer Research Institution CLL Research Group. So Anna is really the boss when it comes to managing through and developing the future in the CLL clinical trial strategy space for the UK, but not only in the UK. Anna has also got a leading role with the International Workshop on CLL on an International Development Committee. So I think there might be some interesting questions that I might be able to pose to Anna that have come from her presentation. On that note, I'd just like to say to everybody, welcome. Please enjoy the day. Please ask questions. And please I think I have another reminder as well. I forgot to review something. We had a little magic show last night for half an hour. If you want a bit of light relief, it's great fun, actually. I thoroughly enjoyed it. That's on demand as well. And as we said, all sessions that were pre-recorded have been pre-recorded. If you haven't had a chance to visit, be here Friday or Saturday, just drop in and have a look when you can. The platform's open for you for the next 6 months. With that note, I'd like to hand over to Professor Contam.
Hello, everyone. My name is Contam. I'm from Peter MacCallum Cancer Centre and University of Melbourne in Melbourne, Australia. And I'm very sorry that I cannot join you live tonight due to the time zone differences. Tonight, I'm going to talk about the treatment algorithm for CLL that has either relapsed or is refractory to standard therapy, meaning that CLL that has previously been treated. And I just want to provide a historical perspective on this problem. So as you know, for several decades, that chemoimmunotherapy is a standard of care for CLL with various forms of chemotherapy regimen, including FCR, bendamustine rituximab, and chlorambucil obinutuzumab, used in patients with different degrees of fitness. So very fit patients get FCR, and those older patients who have got less good organ function receive chlorambucil obinutuzumab. The problem with chemotherapy-based treatment is that usually the CLL cells develop resistance to the chemotherapy-based treatment, and then subsequent to that, we recognize that there is a subset of patients who carry a deletion of p53 or deletion of 17p, and this is recognized to be a marker of resistance to chemotherapy. For these reasons, we have now migrated onto the age of what we call the novel non-chemotherapy treatment, and this is the age of the targeted therapies. But taking you back to, I mentioned before that deletion of p53 or 17p deletion confers resistance to chemotherapy. I will show you the data from 2 studies published in the chemotherapy age. And these are Kaplan-Meier curve, which shows the percentage of patients who remained alive over a period of time. In the left panel here, you can see that in the CLL4 study, which is a study comparing fludarabine with fludarabine cyclophosphamide, 2 forms of chemotherapy, that patients with deletion of 17p has a shorter survival than those without. On the right, you can see that the patients in this German CLL group, CLL8 study, treated with the FCR chemotherapy, you will see in the black line here that those patients who have got a deletion of 17p of p53 gene, once again, has a shorter survival after treatment compared to other groups of CLL. So we know that chemotherapy is ineffective against CLL that carry 17p deletion or p53 mutation. How common 17p is depends on the stage of disease. So most patients who are at diagnosis, less than 5% will carry this marker. And then by the time patients come to first-line therapy, they become resistant to standard chemotherapy. And by the time they become resistant to standard chemotherapy and antibodies, you can see that the rate of 17p deletion increases up to about 50% of patients. So a typical CLL patient who makes it through many different lines of therapy will have an increasing chance of acquiring this 17p deletion, which means that the patient would then be resistant to chemotherapy. We also know that how long someone responds to chemotherapy determines how well they do. So this is a study that we published many years ago, looking at the results of retreatment with FCR. And you can see that patients who have got a shorter duration of treatment to the first cycle of chemotherapy. So the first time they got chemotherapy, the response rates were less than 3 years. When they were subsequently retreated with chemotherapy, they do very poorly. Whereas those in the green curve here, where the initial remission duration is more than 3 years, they do relatively better when they are retreated with chemotherapy. So we know back in 2010, 2011, that we had these patients who have 17p deletion, who had resistance to chemotherapy. And these patients were very hard to manage because they were very sick and they had low blood counts, and the leukemia really responded very poorly to what we had. So the first major treatment that we saw that where there was a consistent response was this drug called ibrutinib, which inhibits an enzyme called BTK. And this is what we call the waterfall plot, where every bar that goes below zero, i.e. all these bars here, shows a reduction in the degree of disease in a single patient who took this drug on a phase 1, phase 2 trial. And you can see that in this very difficult group of patients where we would expect only very few to respond to therapies, the ibrutinib basically achieved a reduction in CLL across almost every single one of the patients treated. So this was a major breakthrough in an age where there was very little light and there were very few treatment options. And that really led to the new age of the novel therapies in CLL. Ibrutinib was a tablet and it was easily taken by mouth. And this is a slide that was courtesy of my friend, Jan Berger, one of his patients who, as you can see, has got very large lymph glands in the neck. Before she started ibrutinib, I believe that this patient has been treated with many rounds of chemotherapy and eventually became resistant to chemotherapy. And you can see that within 2 weeks of starting this tablet called ibrutinib, that there was a marked reduction in the amount of lymph glands in the neck. And after 3 months, that the lymph glands have totally resolved. So, and this is not just a single patient. Virtually every patient that I treated with ibrutinib had such a dramatic responses where they started on a tablet and within a few days, the lymph glands start to shrink. And by about 2 to 3 months, the lymph glands have regressed by a very large amount. Ibrutinib was therefore compared against a standard treatment in a head-to-head study. This is a randomized study for patients where the CLL is what we call relapsed refractory. So i.e. the CLL has stopped responding to the usual treatment. And you can see that in this head-to-head comparison of ibrutinib versus a drug called ofatumumab, which is basically the best drug that we had before ibrutinib came along. You saw that really there's a very clear difference with ibrutinib being markedly superior to ofatumumab, which is the best of what we had before ibrutinib came along. And this is a study called Resonate, and this study led to ibrutinib being accepted as the standard of care for relapsed refractory CLL across all the countries across the world. But ibrutinib does have a few problems. So compared to chemotherapy, it was much easier to take. It had far fewer side effects. It doesn't affect the blood counts as much, but it did have a few interesting issues. Firstly, we noticed that patients with ibrutinib started to get bleeding. And it turned out that ibrutinib is very potent and inhibiting a clotting element in the blood called platelets. So ibrutinib basically causes the blood to be thin and not to clot in a normal manner, in much the same way that aspirin causes the blood to be thin and not to clot. So bleeding was a problem with ibrutinib. And the problem was that many of the patients and the surgeons did not understand that ibrutinib was a drug that causes the blood to be thin. And these are two of my patients who had surgery with removal of skin cancer on their foreheads. And they did not stop the ibrutinib before they had surgery because the surgeon did not recognize the drug as being a blood thinner. And both these patients developed very nasty bleeding after the surgery. So an important lesson with this new drug ibrutinib was that I always tell my patients to stop the drug before they have any surgery because the drug is a very potent bleeding factor, a very potent antiplatelet drug, and it can cause bleeding if it is not stopped before surgery. So the BTK inhibitor ibrutinib was really a major breakthrough. It saved many of the lives of my patients, a lot of whom are still alive today. When before the days of ibrutinib, they would have survived probably 12 months maximum. It did have some problems. I told you about bleeding as a problem of ibrutinib. It can also cause a heart arrhythmia called atrial fibrillation. And we now understand that atrial fibrillation probably occurs in up to around 15 to 20% of patients who take ibrutinib. And although this is a common arrhythmia found in older patients, just older patients without CLL and not taking the drug, if you take ibrutinib, the risk of atrial fibrillation increases many times above normal. It can also cause high blood pressure, which in the long term is detrimental as it increases the risk of heart failure and strokes and heart attacks and other cardiovascular problems. Lastly, although ibrutinib in general is very well tolerated, it is associated with a number of nuisance side effects, including rash, occasional diarrhea, and probably one of the most disabling side effects is joint pains. So many patients develop pains in their joints that in some patients are intolerable and led them to stop ibrutinib altogether. And we think that many of these side effects happen because ibrutinib, although it's a pretty good drug, is not exactly as clean as other drugs could be. And so therefore, we have now improved the versions of ibrutinib, which are called the next generation BTKI or the next generation BTK inhibitors. And this drug inhibit the target BTK in a much cleaner manner than ibrutinib, therefore providing the opportunity for less side effects. And indeed, I'll just show you one of these drugs. This is a drug that I've worked with for many years. It's called zanubrutinib or BGB-3111. And the circles here show the enzymes in the human body that ibrutinib inhibits. And you can see that in addition to BTK, which is somewhere in here, the ibrutinib inhibits many other different enzymes, and it's not very clean. Whereas the zanubrutinib is still not totally clean, but it's a lot cleaner than ibrutinib in inhibiting other enzymes. In addition, zanubrutinib also gets to have very high drug levels in the body. And because it is more clean than ibrutinib, we have the potential to push the dose higher to get more drug into the patient and yet not increase the risk of side effects. And indeed, there are now 3 randomized studies where a second generation drug, and in this case, zanubrutinib, but the same can be said for acalabrutinib, was compared against ibrutinib. And in these head-to-head randomized comparisons, the new drug, either zanubrutinib or acalabrutinib, is much less likely to cause side effects compared to ibrutinib. So shown here are the risk of atrial fibrillation over time. You can see that when patients start ibrutinib in this study, that up to about 20% of patients end up getting atrial fibrillation, whereas the rate is much lower with zanubrutinib, remaining at less than 5%. And the same thing with severe hypertension, that over time, the patients taking ibrutinib in the blue curve are much more likely to get severe hypertension compared to those who take zanubrutinib in the red curve. So the important lesson to know about the second generation inhibitors are that they're much less likely to cause side effects than ibrutinib, therefore making a really good drug even better. I'd like to spend some time to talk about the other classes of new drug, and these are drugs that inhibit an enzyme called BCL2, which is an enzyme that stops the cancer cell from committing suicide. And this is one of our patients who was treated with an early generation of this drug called the Navitoclax. And what you're looking at here is a scan where he has a very large tumor mass, as shown in my arrow here. And then after a few weeks of this therapy, you can see the tumor mass has shrunk a lot. And this is because, and same here on this side, you can see there's a very large tumor mass in the belly, which is almost completely gone after 10 weeks of therapy. And what these class of drugs do are that they are tablets that causes the cancer to commit suicide without having to require chemotherapy. And this drug is now most manifest by a drug called venetoclax. So the BCL2 inhibitor that is now out there in the market is called venetoclax. And the venetoclax has been compared against chemotherapy, in this case, bendamustine rituximab, in a study called Murano, where, as you can see, the venetoclax containing regimen had a much better control of disease compared to the standard of chemotherapy. So now we have got 2 classes of drugs which are most effective in relapsed refractory CLL. We've got the BTKI, which is the ibrutinib class, and then the BCL2I, which is the venetoclax class. So which one do we use first? And that is always a question that is difficult to answer. We know from the earlier study that if you develop resistance to ibrutinib and you give venetoclax, that it is effective. So the classical sequence in the US is to give ibrutinib first, followed by venetoclax. In Australia, we're in a slightly different place because we actually developed venetoclax before we developed ibrutinib. So we now have experience that if you develop resistance to venetoclax and you give ibrutinib, ibrutinib works really well. So really, you can use either of the drugs in either order of your choice, and they will both work in either direction. However, those patients who become resistant to both ibrutinib and venetoclax have no real good treatment options, and that is where the area of need is in 2021. So why would you choose ibrutinib over venetoclax? For a start, ibrutinib is easy to start and has a very low risk of a complication called tumor lysis syndrome, which is where you kill off too many cancer cells at once and you damage your organ through a release of toxic chemicals inside the cancer. The drawback of ibrutinib is that it's indefinite therapy. Once you start on it, you have to stay on it, because if you stop it, the cancer cell will start to grow again and the leukemia will come back. As I described before, ibrutinib can also cause bleeding, atrial fibrillation, and hypertension. Now, why would you choose the reverse sequence? Why would you prefer venetoclax over ibrutinib as a first drug? And the real attraction to venetoclax is that it is a time-limited therapy. So instead of ibrutinib, where once you start on it, you have to stay on it for long term, for venetoclax, you only take it for around 12 to 24 months, and then you can stop. And the cancer will grow back over many, many years. The drawback to venetoclax is that it can cause this problem called tumor lysis syndrome. So when you first start the drug, you have to have lots of blood tests to monitor your kidneys and your electrolytes very carefully. And it should probably be given with antibody, which is an intravenous preparation, in addition to venetoclax, whereas ibrutinib is totally oral. Venetoclax can also cause a neutrophil count to be low and increase the risk of infection. So in conclusion, we're now in the age of novel agents, and chemotherapy, if it's used, is typically only given once, after which we then use either ibrutinib or venetoclax. Both ibrutinib and the next generation drugs and venetoclax work well and can be given in either sequence, and really the choice of choosing which one to start with may well depend on the logistics. The treatment gap in 2021 are those patients who become resistant to both venetoclax and ibrutinib, and we are very lucky that there are some exciting new drugs which are being developed out there for this area. It is very exciting to work in CLL. I'm very glad to have the opportunity to work with patients with CLL and to make these drugs available. And I thank you very much for your attention.
Hi, my name is Dr. Munir. I'm a hematology consultant at St. James's Hospital in Leeds. I would like to thank the organizers of CLL Horizons to ask me to talk, and my talk is primarily on complications of chronic lymphocytic leukemia. So how I have structured this talk is talking about the comorbidities in CLL and how does that impact in our treatment choices, as well as the outcomes of the patients who have got different comorbidities. And then talking specifically about the complications of chronic lymphocytic leukemia, the infections in CLL, which is a very hot topic at this moment in time, as well as the autoimmune complications, and briefly talking about the dreaded complication of Richter's transformation. So in terms of the comorbidities, it is becoming quite important for us to map the comorbidity in CLL. And there are lots of data that is looking at this question, but I've just picked up the one paper which was recently published from the Danish CLL registry. And the Danish CLL registry is quite interesting because it picks up all patients with CLL so that there is no missing data at all. And you can see that this is a 20-year follow-up on these patients with a total of 9,170 patients. And how they have divided the patients of CLL is that the patients have had no morbidities, no comorbidities. The comorbid patients are who have got 2 or less than 2 other medical health issues, or multiple morbidities, which means that more than 2 abnormalities in various organ function. And you can see in this table that a lot of patients have had different comorbidities, including cardiac problems. Some people have had stroke, some people have had dementia, diabetes, other issues as well. And they have been able to look at the combination of these comorbidities. And you can also see that the average age of different patient groups with these comorbidities is highly representative of the CLL population that we see in our clinical practice. And overall, what they have been able to say is how these comorbidities have been able to impact patients over time. So if we go to the graph on this side, they've divided these 3 groups into non-comorbid, comorbid patients, and multimorbid patients. And whichever group you look at, it is quite clear that infection is the major cause of death in patients with CLL. And then the second most common reason is CLL itself. So whether there is no comorbidity, or there is comorbidity, or multiple morbidities, the causes are pretty much the same. And the last graph that they've been trying to show us is looking at patients with CLL above the age of 70 or below the age of 70, and they've compared that to age-matched control in those cohorts. And what is clear is that the comorbidities has an impact on the overall survival of the patients in the age groups above the age of 70 or below the age of 70. So in short, it was clear from this study that the survival was inferior in CLL patients as compared to age-matched comparator. Infection was the most common cause of death, independent of comorbidity, and all comorbid conditions were individually associated with increased morbidity and mortality. And essentially, that is an important thing to remember, that when we are designing the trials for our CLL patients, we take the comorbidities into much deeper context. The main issue that obviously that study defined was the infection. And we know this is a very kind of complicated diagram, but this is what we find in CLL patient. And the important thing is secondary immune deficiency in CLL, which means that our patients' immune systems are low. And these are complex mechanisms here, which I won't go into the detail of. But essentially, what we find in patients with CLL is low levels of these normal antibodies called the immunoglobulins. And then there are other things like affecting the other part of the immune system, which makes our patients vulnerable to infections. And we know as the disease progresses, the immune dysregulation happens. The low IgG levels are seen, and normal B cells, which make antibodies, fall as well. And then there is poor response to make antibodies. And then there are other type of immune system components like the complement system, and the helper T cells start to decline as well, overall resulting in an immune deficient state in CLL. And what does that predispose our patients to is infection. So I've put down the CLL related risks. And essentially, this is the same as what I was showing in the last diagram. But then we have got the therapy related side effects, which include steroids, other medications, which will suppress the immune system, and some chemotherapy drugs, which causes neutropenia. And then we had to check our patients for hepatitis test before we start the treatment. The infection accounts for 30 to 60% of the mortality in CLL patients. The 5-year risk of severe infection is 26%, 57% in patients with low IgG levels, and 68% in patients with low IgG level an advanced stage of CLL. So how we can tackle the infection risk in our CLL patients. So vaccinations are the cornerstone. And to prevent pneumonia, we normally would suggest that patients have 2 vaccines. One is called Prevnar, which is a pneumococcal vaccine with the conjugate, and it only covers 13 types of pneumonia strains, followed by a PPV23, which covers 23 strains, although a weaker vaccine. So this is different to patients, other normal population who gets pneumonia vaccine. Then we advise our patients to have the PPV23 every 5 years. I would suggest we should assess the response in our patients. All our patients should have yearly influenza vaccine. We should avoid live vaccines, but and Zostavax is an example which prevents shingles. But there is a Shingrix vaccine available, which is a dead vaccine, and we should have that. All our patients should have that, but there might be constraints due to the funding issues. The response to vaccinations are poor, and there is also poor response to other vaccines like H influenza and hepatitis B vaccine as well. In patients where vaccines are not working very well, then prophylactic antibiotics like azithromycin to prevent chest infections. And in patients where antibiotics don't work, if the IgG levels are low, then replacement intravenous immunoglobulins is given every 4 to 6 weeks. And I would suggest that majority of us will give PCP prophylaxis and antiviral treatments for patients who are receiving therapy for CLL. What about Shingrix vaccine? So this is a dead zoster vaccine, and it is to prevent herpes zoster in patients above the age of 50, which majority of our CLL patients are. And this is some data from patients who've been on ibrutinib. There's 22 CLL patients and 10 other lymphoproliferative disorder patients who received the zoster vaccine. And you can see that 3 out of 4 patients have had a response, which suggests that this is a decent response. And we were able to see T-cell responses in these patients, suggesting that this is beneficial even on patients who are on continuous therapy. What about COVID vaccine? And that's, we might talk about it later. I assume this is the data from UK studies, 69-year-old median age group. And we can see that the first dose antibody response was only 34% as compared to a very good 94% response in the normal population. But look at this, the titers were 104-folds lower, which means that the response, even the response was there, the response was lower than the normal population. And second dose antibody response, it is much better picture, 75% CLL cases as compared to nearly 100%, but the titers were 74-fold low. And then they identified as patients who are continuing on ibrutinib or acalabrutinib or a BTK inhibitor or IgA deficiency were associated with failure to generate an antibody response. And there's lots of studies, other studies looking at these questions. Next, we will go to autoimmune cytopenia. So this is another complication in CLL, and this is primarily defined as immune overactivity in CLL patients, causing a drop in the red cells or the platelets. And usually what we find 3 situations. One is where autoimmune cytopenias are present on its own, and obviously in that situation, we normally don't give treatment for CLL, or in patients where we have got both problems, where we might have to treat both issues. And sometimes in patients who've got progressive CLL, then we might have to treat everything together at the same time. So normally, the epidemiology is such that there are 4 disorders we're looking at. Autoimmune hemolytic anemia means that the red cells are low, the hemoglobin is low, and that accounts for a majority of the cases. So 1 in 10 patients with CLL will get that. Immune thrombocytopenic purpura means that low platelet count, and that is seen in 1 to 5% of cases. Pure red cell aplasia means complete reduction in hemoglobin, and primary problem is that the red cells are not being produced by the bone marrow. And neutropenia means, which is a very small number of cases, that it is an autoimmune condition as well. The main problem is the antibody coating the red cells or the platelets, and that what happens then is that the body starts to recognize that we need to kill off these cells very quickly, and as a result of that, the autoimmune issues start to come along, and the red cells and the platelets don't survive. Sometimes this is against the cells, the stem cells, which are producing the red cells or platelets or white cells. So the problem can happen in those areas as well. And there are a few other ways this can have an effect. So if this is considering a red cell there, and there is this antibody, this Y-shaped structure, and then the complement system is coating this red cell. And what will happen in this scenario is that normally the red cell will go into the spleen and get eaten up very quickly, whereas it might go into the liver and get eaten up. Sometimes it can move around a little bit and then gets eaten up. Eventually, the life of a red cell, which is about 3 to 4 months, can be reduced to sometimes few days and to months. And that's why this condition is difficult to manage. So autoimmune hemolytic anemia, or ITP, these can happen usually in active disease with autoimmune hemolytic anemia. With ITP, it's usually not. It can happen isolated time. The median time could be somewhere between 39 to 20 months. And nearly a third of cases of ITP are refractory to standard treatment, and nearly 16% of cases with autoimmune hemolytic anemia. They're usually present in difficult to treat people, which means that they have got difficult cytogenetic or abnormalities or unmutated IgHV status. There's sometimes the drugs that we give to treat CLL can cause these issues. So for example, if somebody has used FCR or bendamustine rituximab, that can induce autoimmune hemolytic anemia. And sometimes Campat, which was an old drug we used, can cause ITP. Ibrutinib rarely causes development of autoimmune hemolytic anemia, but withdrawal of other treatments are possible. And there's some data to say that obinutuzumab may help with autoimmune cytopenias. So how do we treat it? The main treatment is to suppress the immune system, and we can suppress the immune system in different ways, like with steroids, intravenous immunoglobulins, and then there are slow-acting drugs like cyclosporin, azathioprine, or rituximab. Obinutuzumab has been now used in autoimmune cytopenia in a small number of patients with good effect. And then we can think about treating the CLL-directed therapy, and there are various regimens that are used to treat the CLL. Splenectomy, we used to do that in the past, but now we try the medications first before we do that. Alemtuzumab occasionally. And then there are some drugs which can actually stimulate the bone marrow to produce blood cells, like eltrombopag or romiplostim, and this makes the cornerstone of the treatment. Lastly, I would talk about Richter's transformation, which is the dreaded complications. What it is that somebody has got CLL and then develops an aggressive lymphoma on the top of that. It happens in about 2 to 15% of CLL patients if the treatment goes on for a long time, and the risk is nearly 0.5 to 1% transformation risk per year. Unfortunately, this is one of the diseases where the prognosis has not improved despite all the improvements in the CLL treatment. I won't go into the detail of this, but the Richter's transformation depends on the biology of the CLL and the genetic changes that are happening in the clone. But the most important thing in Richter's transformation is the clonal relationship of lymphoma to the underlying CLL. And there's different ways by which we can tell whether this is related to CLL or whether this is a different disease. So what I'm talking about is that whether the CLL clone is giving rise to lymphoma clone, or whether there are two different things there. Why that is important is shown in this graph, that if the clone is the same originating from the CLL cells, then the prognosis is worse. If this is two different diseases, then the prognosis is much better as compared to the clone that is originating from CLL itself. And that is an important information that we want to give. So what we do in our patients, we do a PET CT scan, and then we do a biopsy. And if we have got lymphoma, then we give chemoimmunotherapy. If it is CLL, then we treat it like CLL. And sometimes it can present as Hodgkin's disease, and we treat it with a different treatment called ABVD. Even in the era of the novel agents, still we're seeing Richter's transformation at a rates between 3 to 15%, depending on which study you're looking at. And I've just put that out there. What is the response to the treatment? So this is different kind of regimens which are used. The most common one is the R-CHOP, but I think the problem is that the overall response rate is somewhere in order about 40 to 70%, but the PFS is nearly about 3.5 to 10 months. And the problem really is that the overall survival is also affected. There are studies looking at combining venetoclax with rituximab and EPOCH treatment, which has yielded some good results, but the long-term outcome always is dependent on whether the patients can go up and get an allogeneic stem cell transplant, or now in future CAR T cells as well. There are some checkpoint inhibitors that are being trialed in different in Richter's transformation with some reasonable results, but the long-term follow-up is not there. I've put down some more graphs there, some more schema where umbralisib, which is a PI3 kinase inhibitor, has been used with PD-1 inhibitor, and the results are reasonably good. In UK, we are doing the study where the R-CHOP treatment has been combined with acalabrutinib, and acalabrutinib has been used on its own. So we'll get some results from this data. Lastly, the transplant is a reasonable option for patients who can go into this phase. The very small number of patients, but patients who could have had an allogeneic transplant in remission were the best patients who had the best outcome for this disease. There are loads of trials which are looking at how to best improve the response in patients with Richter's, because it's a real area of unmet need, and we need to do better at defining studies to help. So I think it is important to know the clonal relationship, the incidence rates, its incidence increases as the disease become resistant to multiple lines of therapy. New drugs do not affect the biology of the disease, but I think chemoimmunotherapy is the mainstay of treatment, but within extremely poor prognosis. So I will stop there, and I would be very happy to discuss any questions that may arise from this talk. Thank you for listening.
A warm welcome, everybody, to the CLL Horizon meeting. My name is Professor Anna Schuh, and I'm from the University of Oxford in the United Kingdom. I'm going to give you an update on clinical trials in CLL. These are my disclosures. I won't read them out, just for your interest, you can skip through them. And many of you will have already gone through CLL treatment yourself, so I don't really have to explain to you too much about CLL treatment, but in the past 20 years or so, we've made a lot of progress in CLL treatment. We started off, certainly when I was a registrar and trainee in hematology, with just simple chemotherapy, most commonly used chlorambucil. And although this treatment alleviated symptoms and made people feel better, it didn't really work that well. And many patients actually relapsed quite quickly after receiving chemotherapy. And then a big change happened in 2010 when we first started using bullet treatment like anti-CD20 antibodies called rituximab, and we used that together with chemotherapy. That really changed for the first time the natural history of CLL, in that patients actually lived longer and they had a longer time before they progressed and before they needed more treatment. And then the next big change came when we first started using ibrutinib, and ibrutinib is we're calling it a B-cell receptor inhibitor. It's a target bullet treatment, but not like a monoclonal antibody. It's a very small molecule. And this really was another big game changer. And subsequent to that, there were sons of ibrutinib, acalabrutinib, and now we've got many other drugs, also zanubrutinib, et cetera, et cetera. We also then had other targeted bullet treatments, in particular a drug called venetoclax, and that works in a different way to ibrutinib. So that there've been an explosion of many different targeted therapies, and these really further improved, the time to requiring more treatment, and it also had the big advantage of not having to use chemotherapy. So these targeted agents have got less toxicity, and they are much better tolerated, although they still have some side effects. And one of the issues also is that some of those have to be taken continuously, and so patients will find themselves on tablet drugs all the time, which is not necessarily a good thing. You might identify some of those and recognize some of those names from very important clinical studies. And it's just a slide to tell you that, we don't just come up with all those different treatments. We do have to rigorously assess how good those treatments are. And we do that by comparing, a new treatment against the current standard treatment. And this is what these studies did. And that's why we're having so many different regimen now available to our patients, both for patients who are fit and also for patients who might be not so fit anymore and might suffer more side effects. That's been translated into some guidelines. So these targeted therapies are now available in frontline, in patients who've never had treatment, but also in patients with relapsed CLL. And it really shows the power of clinical trials in then defining guidelines that are known and recognized across the world for treating patients with CLL. And that's really how we work in medicine all the time. Is we establish the evidence from studies, and then we're writing guidelines so that patients can be treated in the same way and similar ways across the world. Now, one of the outstanding challenges, though, is that the novel therapies, although they are really good, they are tablet treatments, they're very well tolerated, they control CLL, but they actually only provide a cure for only very few patients. And so eventually, even although you might be on a drug like ibrutinib or acalabrutinib for several years, maybe even a decade, eventually the CLL will come back. And then you have to go onto a different drug. And so when this develops, the moment we are basically looking at treating patients sequentially over a certain period of time. So we are sequencing targeted agents, and it doesn't really matter so much whether you start with ibrutinib or whether we start with venetoclax. You can switch to the alternative agent, but eventually, over a period of maybe a decade or longer, the CLL will become resistant to these agents. The other way to look at this is by combining the targeted agents at the very beginning. So when a patient first requires treatment, you then start treating. And so that is another interesting area of research at the moment, because we don't know which of the different targeted agents we should combine with each other. So that's one area of research. The ultimate aim really is to cure CLL. So the other big gap in knowledge is basically to have precise biomarkers to better predict progression to the next stage of the disease. And that really starts at the very beginning. So, patients always ask me now, why did I get CLL in the first place? I mean, the short answer is that we don't really know, but we know that it starts probably with one single cell that is a B cell, and that single cell undergoes some genetic changes and might no longer be under the surveillance of the immune system. And so that cell is then being allowed to divide, and initially it divides into something called monoclonal B-cell lymphocytosis, which is a precursor stage of CLL. And then as more genetic changes occur and the immune system becomes weaker and weaker, then the patients will progress, to proper CLL, initially early stage, then late stage, and then they, when they have treatment, they will relapse. And sometimes patients also transform into a more aggressive lymphoma. So there's various progression stages in CLL, and at each of them, it would be really helpful, if we could predict progression in a very precise way from one stage to another. So we do have some predictors. We have got some genetic changes, in particular in something called TP53, which is a gene that is needed to control CLL. When that's mutated, then that's really bad. And then we have also a sign of the immunoglobulin status, IgHV mutation analysis, that helps us to identify whether you have more of a mild form of CLL or more of an aggressive form of CLL. But really, we know very little about the immune system and how important the immune system is in preventing CLL from progressing. So that's one gap in knowledge. And then, and this is my only sort of scientific slide, the other area where we are now looking is basically if we're sequencing, if we're trying to identify all the different genetic changes that we have in CLL, does that actually help us to further identify CLL patients who have a different outcome? And so we've done some of this as part of the Genomics England program in the UK, where we've performed whole genome sequencing, and we identify additional genomic subgroups that are in addition to the ones with TP53 abnormalities or immunoglobulin abnormalities. And then interestingly, both ourselves and others have also got data that shows that even by taking a simple blood test and looking not at the CLL cells themselves, but at the genetic material, the DNA that is in the plasma, that from that plasma DNA, we can also identify mutations that might predict a higher risk of progression to something, for example, like Richter's transformation. So we're trying to increasingly use simple tests that are non-invasive, that are really simple blood tests, to try and find signatures and hints that of progression in the sample. And that's really important because that will help us to stratify patients. And one of our studies in the UK called Oxplode is a study that now looks at identifying those markers of progression very early on in patients who don't actually need any treatment as yet clinically. The reason being that we want to reassure all the people who will never progress to CLL, but also at the same time identify those few ones who will progress and try and treat those very early on before before that progression, that relentless progression process can happen. So that's it's an interesting study, and you can read up more on this on our website, and you've got the QR code there. So how about patients with established CLL? What are the new concepts here? So I've already mentioned, the combination therapy is definitely something that we are testing in clinical trials. The other thing that the other concept that we have, and this is the slide from the German CLL study group, but it's very similar in the UK, is that we are trying to treat this CLL really, really hard, and then we will measure very residual disease, very little amounts of disease, to see whether we can eradicate that little disease more effectively. So if some patients are MRD negative, at the end of treatment, we will just continue either with the same treatment or even stop the treatment. Whereas if they have got significant levels of CLL left, we will then treat them with other targeted novel agents. And they are listed down there. I won't go into them, but there are many other treatments that are becoming available now that we think will be particularly good at eradicating this very little leftover disease. And a lot of those treatments actually target the immune system, because we know that the immune system is very good at eating up small amounts of disease. One of the examples of such a study is the UK array study that is still at the concept stage at the moment, and we're hoping that we will very soon be able to start progressing with this study, but it's still some time off before we actually can recruit patients. And this study will use exactly the same principle. It uses a combination targeted therapy at the beginning, as highlighted here, against the current standard of care in the UK, which is venetoclax and obinutuzumab. And then after a year or so, we will measure the very little amount of DNA that of CLL that is left. And if there is some left, then patients will get further therapy. If there's none left, they will stop treatment and they will just be observed. So the other challenge that I was asked to talk about is the access to clinical trials and drugs in different countries. And of course, that's a very long topic, and I won't go too much into details, but it's very clear that a lot of different stakeholders are involved. You need good regulatory bodies that are open to discussing clinical trials with you. You need a network of clinical trial units to run multi-center studies, because simply for a disease like CLL, it's quite rare in the great big scheme of things. You can't do these studies in just one center. You need big collaborative studies. And then you need a lot of different professionals, healthcare professionals, who are trained to actually perform clinical studies safely and effectively. And last not least, you need engagement by pharma. So it's a very complicated process, and it's in particular for emerging economies, it's not trivial to get all these different things in place. But one very interesting thing I want to mention, because it was a press release just about 5 days ago now, where a very new pharmaceutical company called EQRx and NHS England signed a memorandum of understanding to basically try to promote and commercialize 2 different cancer drugs in a very innovative way that is effectively, two-thirds more or less expensive than the current access to clinical to drugs and cancer drugs. So this is, I would invite you to have a closer look at the press release, but that might be one of the ways forward of trying to reach access to drugs and to cancer drugs in a much more cost-effective way. And so then the final question is the question of what really the patients should play, the role patients should play in developing clinical trials. And that is really the key question of all, in my opinion, in particular when you're thinking about setting up a clinical trial infrastructure and also accessing cancer drugs more generally. So the UK National Institute of Health Research has come up with a few principles called the Involve principles. There's 32 of them actually. And it's quite a big document. And again, I've left the QR code there for you to read up on. But basically what Involve says is that patients should be involved at all stages of research. They should actually set the research agenda and prioritize studies. They should be involved in design and management of studies, in data collection analysis, and also in the dissemination and reporting of findings. And so we try to, in the Oxford study, we try to really realize all those different principles. And in fact, the Oxford study, which it looks at recruiting people with a precursor CLL and MGUS, that study came along because of the Watch and Worry campaign that was initiated by one of our patient support groups in the UK, and was based on the fact that many people are being told that they have got something that could evolve into myeloma or into CLL, but actually, we don't know whether it will or not. And so that causes a lot of anxiety. And we want to really try and find biomarkers that can reassure patients. So they were involved at the rational and the design stage. Patients are involved in the day-to-day operations and within the trial management group. They sit on steering committees because during that they can review milestones and progress, address obstacles, and also agree to changes to the protocol. They sit on scientific advisory boards where we set and review scientific objectives and also interpret data, which I think patients are increasingly getting involved with and should be getting involved with. And they, of course, review protocols and patient information and so on, which is sort of the more classical patient involvement that we are aware of. I think it's really important that studies have defined budgets for patients and for patient involvement, be it for educational events, participation in trial-related meetings, attending research conferences, and also when it comes to promoting studies and reporting progress and results back to the patient community, so that patients also feel encouraged to recruit into or to participate in studies. So in conclusion, huge progress has been made when it comes to clinical management in the last decade. We have well-tolerated and effective therapy. And, in some instances, we think that they are probably curative for patients. But the next target is really the cure. And that means that we need to think about eradicating the little bit of CLL that is left after doublet treatment. And then also about the earlier treatment and the intervening earlier. For that, we need the biomarkers to identify those patients at risk of progression. In order to keep all stakeholders engaged, we really need patient involvement at all levels of drug and precision diagnostics development, so that we can, it's not just about recruiting patients into studies, but basically also leaning on pharma, leaning on the regulator, so that they see that patients with CLL, that there's still very much an unmet need. Thank you very much for listening. And I'm happy to take any questions in the live Q&A session.
Thank you, Anna. And thank you, Tal. Terrific talks, very revealing, and they offer an immense amount of hope. And just to let the audience know, the Contam, I don't know if I mentioned earlier, because of the time difference, he's unable to join us. So any questions you fielded for Con, I'll share with Anna and Tal. Yeah, lots to take on board. I think what I'd like to do, if it's okay with you, we've got an awful lot of questions, which is great to see. Everybody's engaged, and lots of questions the talks have raised. I guess what I'm looking at the moment, I'm just having to scan. If I was to deal with some of the first questions that related to the first talk, the first question is a question regarding sequencing and potential progression, which was when comparing ibrutinib and venetoclax, do we see a difference in drug resistance between either or? That's been voted to the top of the question. Do we see more resistance in venetoclax? Any knowledge in that area?
Maybe I can just comment on that. I think if you're looking at frontline setting, Nick, it's clear that venetoclax is being used as a fixed duration therapy, and it is only for 12 months, along with the venetuzumab. That's what the approval is. So the chances of any kind of resistance is not much there at this moment in time, although we know that people are relapsing 3 years down the line after stopping therapy with Ven+. So ibrutinib or any BTK inhibitor is a continuous therapy, and the longer follow-up data on Resonate-2 study with ibrutinib, the rate of development of resistance is much lower as compared to what we see in relapsed refractory setting. There have been occasional case series of patients acquiring BTK mutation, but that is nothing as compared to what we are seeing in the relapsed refractory setting. So the answer to the question was probably is that resistance is not becoming a major issue, but with the prolonged follow-up, we might see a difference as well.
Thank you, Tal. That was a very comprehensive answer. Anna, do you have anything you wanted to add?
No, just to say that there's good evidence that sequencing works in both directions. So, because I think that was the other part of the question, wasn't it? So when you start off with ibrutinib, and like Tal says, you start with a BTK inhibitor, you'd be likely on therapy for years and years and years. And if patients come off, then it's more likely in the first 2 years for side effects, not because they've developed resistance. Then subsequently, if ever they do develop resistance and they relapse on BTKI and frontline, then they have got venetoclax. The other way, it works the same the other way around. So once you've had venetoclax, maybe once, maybe twice, and then you really need to switch to something else, then ibrutinib works, or any other BTK works really well.
Thank you, Anna. And yeah, I think what Tal's first question alluded to, the treatments of a fixed duration offer several benefits to the patient. One is preventing the potential for future clonal evolution, because you're off treatment, you're off therapy, so you're not being influenced by further use of the drug and therefore further evolution. And the other is a treatment gap and potential quality of life for the patients with that treatment. The next question, a very interesting one. Thank you, attendees, for these submissions. The new BTKI, the non-covalent next generation LOXO 305, are there any head-to-head trials with that against either first or second generation BTKIs like ibrutinib or acalabrutinib? And how is it comparing? Do we know with regards to efficacy and side effects? Setting aside its ability to overcome some of the old BTKI mutations and resistance. So I'm guessing what that question means is it's a drug that can be used after you fail, or if you fail, either acala or zanubrutinib or ibrutinib.
So as far as I know, there's no head-to-head trial between pirtobrutinib and Zanu, acala or ibrutinib, but there are some planned trials in near future. At the moment, the trial which is running, the pirtobrutinib is for patients who've had all lines of therapies before, and that has been being presented with very good results, telling that essentially this molecule is there to stay and actually is a very good addition to the armory of drugs that we've got. The trials which are coming along with pirtobrutinib, and my understanding is one is where pirtobrutinib has been compared to Idela rituximab or bendamustine rituximab, similar to Ascend trial. And then there is a trial which is looking at pirtobrutinib with venetoclax rituximab versus venetoclax rituximab in the relapse setting. And then there is a frontline trial where this molecule is being compared to bendamustine rituximab. So I think the frontline trial in countries where chemoimmunotherapy is not being used, it's not a standard of care anymore, it's difficult to run in those countries. But its pattern is similar to what other molecules have come through. They have shown their efficacy in the relapsed refractory setting, and now they're moving to the frontline setting. I think the intriguing question for me would be that if we use a non-covalent BTK inhibitor, which is able to salvage our patients from people who have had ibrutinib or acalabrutinib, Zanu before, is whether if we use it early on, whether we would be able to salvage patients with other covalent BTK inhibitors, which seems unlikely. But it is definitely a great drug in terms of a lifeline for some of the patients who have had nearly every line of therapy, and it's just very easy to take, and the side effect profile is very good as well.
That's a very comprehensive answer. I'll leave that one there. Thank you very much for your question from the audience. I guess really needs asking. I think Con's talked about some of the issues around bleeding in ibrutinib, and it's obviously raised the question for both of you, Anna, treating a patient with ibrutinib, when would you advise a patient to stop use of the treatment before invasive surgery?
Well, so it really depends, but usually I say that they should stop a week beforehand, and then they should restart when there is no longer risk of surgical bleeding, which is usually maybe within 3 days of having had the surgery. There's very little right or wrong. Probably people can do things slightly differently. Obviously, in an emergency situation, you just have to be careful and watch out for any excess bleeding if you haven't had time to stop it. But it's not a big deal if you stop the ibrutinib for a few days. Same applies for drug interactions. In order to keep it simple, when people need to go on antibiotics for a week or so, things like ciprofloxacin or any kind of antibiotics that interfere with ibrutinib, I tend to say that they should just simply stop the ibrutinib or reduce the dose for that matter.
That's really helpful. Thank you. Whilst I've got you, this is probably up your street. It's a question that relates to that. Could you explain, I'm assuming it's with Con's talk regarding move from FCR to the new BTKIs, but can you explain clonal evolution that may occur with FCR use, especially in patients with a 17p deletion? I don't know if that's the 17p bit's relevant, but I know you'll be able to perhaps tackle the other.
I mean, I think we're sort of all suspecting, and this is not just suspicion, but it's sort of reasonable, intelligent guessing, that chemotherapy will damage the genetic material in the cells even further. So on the one hand, yes, you're killing off all the bad cells, the leukemia cells, but at the same time, you might be also in a few cells then generating additional changes, mutations in the genetic material that then lead to more for those leukemia cells to grow out again. So that's kind of one issue, I think, with chemotherapy in general, not just FCR. I think then that that's obviously it's something that would also contribute to explaining why we cannot cure patients with chemotherapy. I think there's then a specific issue around 17p and TP53, which is the gene that is located in this part of the chromosome 17 that's deleted in some CLL patients. And basically we know that TP53 is really important because it stops these cells from surviving when they acquire additional changes in their DNA. And usually what happens is that the TP53 gene will just message to the cell and says, well, you look really abnormal, you have to die. But of course, when you don't have TP53, then that message doesn't come across anymore. And so that the leukemia cells will then continue to divide and to live. So that's why we see more clonal evolution, we see more of these abnormal cells coming along and surviving and being quite happy when you don't have TP53. So that's I think in a nutshell what the problem is and it's aggravated when you give chemotherapy. It happens anyway. When you give chemotherapy, then that's aggravated this problem.
Thank you, Anna. So that's really revealing and explaining the reason why chemoimmunotherapy is not suitable for the 17p deleted population and of less suitability now that there are other more effective treatments in general population to prevent future clonal evolution. Yeah, I'm going to try and skim through a few quick questions. I was going to tell apologies for this one, but whilst I have Anna on the line, actually it's for both of you, apologies, because it was in your talk. So yeah, go to Tal first, or to Anna. Will the risk of Richter's increase as patients live longer on novel treatments? And do certain treatments increase the risk of developing Richter syndrome?
I'll let Anna answer that question.
Yeah, so I mean it's a complicated one. So the number one, do we see more Richters? No, I think we don't see. As an individual, you're not at a greater risk of getting Richters just because you're living more. But overall, because people will live longer with CLL, there might be a higher risk of getting Richters because you just live for it so that you have got time to develop it. Now, having said this, I think we are all hoping that because we are no longer using chemotherapy, that actually and the disease is so well controlled, especially when you have very low levels of minimal residual disease, that then the chances of or the risk of getting a very bad genetic change that then leads to Richters, that risk is so much lower, hopefully, when you are treated well and effectively and not with chemotherapy. That is kind of what we are hoping, but we haven't got the data yet, and it will take years before we can actually kind of be able to see this trend. I think there's apart from the mutations, we shouldn't forget. We all learned about the immune system in the last couple of years. I think it's really important that to bear in mind that patients with CLL, generally speaking, have an immune system that doesn't really work very well. both with the B cells and with the T cells. And we see what we call T cell exhaustion. And it might well be that that also plays a role over time. It's the longer you have CLL, the more you live with CLL. Yes, we are keeping, the CLL under control, but we are not really kind of improving that much the T cell system and the immune system of the T cells. And so I think that might also then contribute to, to no longer having the immune surveillance for very bad disease like Richter's. I hope that makes sense. And that, yes. I can follow on with Deborah, you want to ask the next question?
Yeah, the next question concerns the long-term use of ibrutinib, especially in younger patients, and they wonder if patients should be checked on a regular basis by consultants for issues like cardiac issues, heart issues.
Yeah, I think that is absolutely the right thing to do. I think we kind of underestimated the problems with BTK inhibitors, especially ibrutinib. But I think the data is becoming more strong now that there is a cardiac signal that we are seeing with ibrutinib treated patients. And it is becoming more paramount that we look out for hypertension, we look out for atrial fibrillation, and education is very, very important because a lot of us, and I would include myself initially, we normally let our general practitioners manage the hypertension and maybe the atrial fibrillation. But I think over long term, if patients are continuing the therapy and if they're tolerating the treatment well, then we need to be looking out for these side effects. And the main reason for that is that if we control the side effects well, then we will still see the benefit of the BTK inhibition. So it becomes very important that we look out for these things, treat it appropriately, and prevent the complications which can occur with this long-term BTK inhibitors.
And Tal, would you recommend that patients stay close in touch with their other healthcare practitioners then?
So I think it's a close liaison between the hematologist and the primary physician. And I think the important thing to say is that our job is to highlight the risk to our primary physician who might not have managed any patient with ibrutinib or a BTK inhibitor. So I think it's very important that if that connection is strong and being communicated appropriately, then I think that is very good in terms of, because a lot of patients who actually develop atrial fibrillation will need to be on a blood thinner as well. So it becomes very important that that communication is there. If that is not there, then obviously with the cardiologist and ourselves, then we have to communicate appropriately to get the best outcome for our patients. But I think it is important, we all are realizing that with continuous therapy, we have to be careful and we need to look out for these side effects.
Thanks very much. Anna, maybe you could answer this question. At what stage would you recommend stem cell transplantation for complex karyotypes like IGHV unmutated, TP3 mutated, ATM mutated, and trisomy 12?
Yeah, that's a very good question. Obviously, the most important part of this is what the patient wants and what the patient can tolerate and how old the patient is and what the general fitness is of the patient. The vast majority of our patients with CLL, they will not probably tolerate a bone marrow transplant, even a reduced intensity transplant that well. So I think that's the first consideration. I think then following on from this, let's say this is a fit patient in his 50s or early 60s without any prior comorbidities. Personally, I say that they need to be refractory to at least one of the targeted agents, be it ibrutinib or venetoclax. And then you have when patients then relapse, and remember that they might get 4, 5, 6, 7 years out of this without in frontline with this treatment, without in particular with the ibrutinib therapy. And then at relapse, they could have the second targeted therapy, and they would then, once they've responded really well to that second targeted therapy, I would then get the transplant team to review and to consider them for transplantation. So the idea is basically that because you need to get into very good remission, and by giving continuous dose ibrutinib first, you make sure that patients will have a really good response in frontline, and then when they relapse, you can get venetoclax and they will get a very deep response. And then after that, once they've achieved that deep response, they can then be consolidated by bone marrow transplant. That's how I would do it. But I don't know whether Talha's got any other views.
Not really. I think with the complex karyotype, and the question is about complex patient who has got these abnormalities. I think the issue is that if we've got basically two very strong treatments for our patients in this setting, and at any point where we feel that actually we can consolidate that with the transplant. And it's a similar question to if you had CAR T-cell availability at that point, whether you would use that at that stage. I think it is a reasonable question to ask, but it all depends on all the things that Anna has mentioned already, depending on the comorbidities, depending on what are the other risks attached to it. It needs to be remembered as well that there is toxicity attached to the transplant as well. It's not straightforward.
Complex situation. Thank you for your answers. So it's about time to wrap this session up. I apologize to many people who have asked more questions that we just don't have time to get to them. I know that we knew that this would be a really popular topic, and I'd like to thank our speakers and our panelists. Anna and Tal, you've done a great job, and I think you understand the patients and the patient situation and are great at explaining things to them. So thank you so much.
Thank you also from myself. I believe I've popped back. Apologies, everybody. But it's been a great session and terrific talks. And Deborah, thank you for stepping in. You saved the day. Sunday internet. Hopefully it doesn't happen later.
Bye.
Bye.
And we'd like to announce that the next session will be in about half an hour. You need to close this session out to log into the next session. So give yourself a little bit of a break, and then our next advocacy session will start. Thanks, everybody.
Thank you.